Can I start?
Please go ahead.
Assalamu alaikum, sir.
Hey, Warahmatullahi salam.
Assalamualaikum Anwar bhai.
Hey, Warahmatullahi salam. কেমন আছেন?
আলহামদুলিল্লাহ ভালো। আপনি কেমন আছেন?
জি, আল্লাহ রাখছে আলহামদুলিল্লাহ।
আপনার ব্যাকগ্রাউন্ড আনোয়ার ভাই, আপনার ব্যাকগ্রাউন্ড ব্রাইটনেস এর জন্য আপনার ফেসটা একটু ডার্ক আসছে। আপনি তো নরমালি অনেক ফর্সা। Nafisa, let's make it start. কামরুজ্জামান ভাইয়ের ভিডিও দেখা যাচ্ছে না। Can you unmute him?
Now it's বলেন না ওপিনিয়ন একটা ইয়েস কথা বলতে চাই। অসুবিধা নেই। ওয়ালাইকুম কেমন আছেন?
জি ভালো, আপনি ভালো আছেন?
হ্যাঁ ভালো আছি। আপনাকে প্রতি সপ্তাহে ডিস্টার্ব করা হচ্ছে বোধহয় নাকি?
Not at all, not at all. I've got plenty of free time.
আচ্ছা।
করোনার জন্য। So I think we are already a little bit 3 minutes behind. Let's make it start, Nafisa.
Respected speaker, foreign and faculty, national and international faculty and learned audience. Assalamu alaikum. I am Dr. Ali Nafisa, oncoplastic breast surgeon, going to start our today's session. You know that the breast management of breast cancer has become complex with newer investigation, wider range of surgical option, huge development of medical oncological, radio-oncological field. We have to embrace ourselves with all these changes to benefit our patients. With the invent of digital mammography, tomosynthesis, high-quality ultrasound, and various localization techniques, management of breast cancer is more multidisciplinary than ever before. Breast cancer diagnosis actually depends on the radiological colleague, and actually the breast screening also depends on them. You know that their quality and quality of machinery for us to diagnose early breast cancer. They say on the imaging, they say something is there. They advise that a biopsy needed. We done the biopsy and we can finally by pathology report. And such a way we can diagnose the non-palpable lump. And then we operate, then we advise the adjuvant therapy. Dr. Humaira Islam Khan has been instrumental and a key member of breast unit and supporting us enormously for over a year and a half. We want to share and disseminate this technique of radiological support, which help us to provide modern of breast cancer. So we are delighted to have her joining us in today's webinar, party to share with us with all benefit, many of us, and more importantly, our patients. And as an international faculty, we have Dr. X.K. Farid Ahmed, General and Oncoplastic Breast Surgery Hospital, Buckinghamshire Healthcare NHS Trust, UK, and as a national faculty, Professor Dr. Shibendu, Professor and Head, Department of Radiology and Imaging, Shohid Sohrawardi Medical College, Dhaka. And we also have Professor Kamruzzaman Chowdhury, Consultant Oncology and Radiotherapy, Bangladesh Specialized Hospital Limited. I would like to invite Dr. Humaira Islam to start her speech. Dr. Humaira ma'am, please.
Thank you. And assalamu alaikum to everyone. Thank you for inviting me in this session. Today, my topic of discussion is how imaging is used in cases of breast lesions. Better imaging means better diagnosis, and then it can be treated better. I have been working with Anwar Khan Modern Hospitals for more than 22 years now, and I hope my talk will be interesting, and I will start. Thank you. Excuse me. Sorry.
Madam, just press next slide. So it will
আসতেছে না।
next. Madam,
হ্যাঁ।
use next page on laptop.
আসে না।
তো এটাকে আপনি আনশেয়ার করেন, শেয়ার থেকে অফ করে ফের রিশেয়ার করেন, শেয়ার স্ক্রিনে ক্লিক করে আবার নতুন করে শেয়ার করেন, ইট শুড ওয়ার্ক। আসসালামু আলাইকুম সালেম ভাই।
আসসালাম। Good.
Now we can see, madam.
Okay. Breast cancer is actually increasingly progressing these days, and we commonly see breast cancers between the ages of 40 to 55 years, and it is one of the primary and leading cause of mortality and morbidity in our country. And prognosis of this disease is directly related to the time of diagnosis and its staging. We routinely do mammographic screening. If we do routinely do mammographic screening, then it reduces the reduction of mortality by 25%. So in these days, we are using various radiologic techniques to do invasive procedures like core biopsy, FNSC, and wire-guided and hydromark insertions. And these helps in diagnosis and therapeutic management of breast diseases. Can you see? Radiological control allows more precise targeting in palpable breast lesions and plays a vital role in detecting subclinical lesions. Rapidity, cost, irradiation, team and availability decides which method we can use for diagnosis of breast cancers. Yeah, this is a picture from Buckinghamshire Hospital, Wycombe Hospital, Buckinghamshire. Dr. S.K. Sheikh Farid Ahmed works. And the first picture is of ultrasound room, and the second picture shows Dr. Vaishali, one of the leading radiologists in the hospital, making some interpretation of tomosynthesis. This is me in Buckinghamshire Hospital in Farid's room. The role of radiologist in breast cancer. In radiology, and in ultrasound, we usually do mammogram and ultrasound for diagnosis. And this is followed by biopsy using various techniques. Usually we do core biopsy, and then followed by core biopsy, we do hydromark insertion, wire clip insertion. And
Madam, please unmute yourself, and again, please, madam, unmute yourself. Madam, please unmute yourself.
হুমায়রা আপা আনমিউট করেন, তারপরে ক্যারি অন করেন।
Diagnosis, radiology for ultrasound, we use diagnosis, mammogram, MRI. And these are followed by biopsy. Ultrasound guided wire localization and marker clips are also done. And marker clips are to locate the site of the because new adjuvant chemotherapy, the lesions may be reduced in size. Sometimes it completely resolves, but the marker clips remain there. So when the size of the lesion is, or if it's a deep-seated lesion, we can always, by ultrasound or by MRI, find out the site of the lesion, which is followed by ultrasound guided wire localization, and then the patient is taken for surgery. And also do skin marking margin assessment. Ultrasound also does work of multiple lump confirmation. What are the types of lesion? There are types of lesion. One is palpable and another is non-palpable. This is a very important diagram where we see the breast. Here we are showing both the quadrants, four quadrants of the breast, which are upper inner quadrant, upper outer quadrant, lower inner quadrant, and lower outer quadrant. The clocks are also shown like 1, 2, 3, 12. And by the location of the quadrants and the clocks, we mention the position of the lesion, and also from we measure the distance from skin depth and from nipple areola. So what will we do in cases of breast masses? Do we do the FNSE or course, or do we do the investigation first? Of course, we do the investigation first, like mammogram followed by sonogram or vice versa. And because if we insert the needle before the investigation, the lump may change in size and shape, and there may be reactionary lymphadenopathy. So it may lead us to a wrong diagnosis. So mammogram and ultrasonogram must be done prior to core biopsy and FNSC of lymph nodes or any other cyst within the breast. And now investigation, we do mammogram in patients in Bangladesh for 35 and above, and ultrasound is for both breast and axilla are done for all ages. And what should a mammography report contain? It is actually more a topic of Dr. Shubhendu. However, as far as I gather, and when I do ultrasound, I always compare my reports and findings with mammography. So I have to mention that what we see in mammography, like microcalcifications, speculations, distortion of breast tissue density, and with mammography, we also see the size of the lesion, the position of the lesion, and we also do Bird's classification from 1 to 5. So we all know by this time what 1 to 5 is. Like 1 to 5 is 1 means negative, 2 is benign, 3 is equivocal or indeterminate, 4 is doubtful, and 5 is definitely malignant. And we do mammographic screening by two methods. One is craniocaudal and the other one is mediolateral. Ultrasound, now about reporting of ultrasound, we see if we find a, we have to mention the position, the quadrant, and sometimes people prefer quadrant. Doctors, they prefer clockwise. So I usually give in which quadrant it is and in which clock it is. And usually we always mention these days the depth of the lesion from the skin and distance of the lesion from the skin and areola. Also, we screen both the breasts to see the number of lesions, and the size of the lesions must be mentioned. Along with the breast screening, screen both the axilla and try to see the lymph nodes, if there are lymph nodes there. And the most important finding of the lymph nodes is we see thickening. If the cortical thickening is more than 4 millimeter, we must do an FNSC for diagnosis that if there's any metastasis within the lymph. And core biopsies are usually done for breast solid lumps under ultrasonographic guidance if it is non-palpable or even palpable. So what is the benefit of early detection and the screening? Like if the cancer is less than 1 centimeter, definitely do not feel it. It is a subclinical size. And along with it, if we do ER/PR, which may be positive, and if HER2 is negative, and if there is no actual lymph node metastasis, chemotherapy can be completely avoided. So the only thing treatment done in this case is surgery of the lump, and that's about it. Now about a patient's journey. A patient who wants screening may be a normal who is concerned about the breast, and this patient may be of any age who is concerned. And there are other patients who come to the radiologist feeling a breast lump, swelling, or discomfort, pain. So what the breast surgeon does is do consultation of the patient and then do physical examination. And if the physical examination is okay, the patient may be discharged from the surgeon chamber. But sometimes if there is anything doubtful, they definitely refer the patient to us. And what we do is screen the patient by ultrasonography, mammography. Sometimes MRI is also required. So it is a multidisciplinary approach, like breast surgeon is concerned, oncologist, pathologist, radiologist, and breast care nurse. And the role of radiologist and sonologist is very important throughout the process of treatment, because from the beginning to the end and follow-ups are all done by us and taken care by other doctors. Now we will say a little about axilla. What we see in axilla, we always try to locate the lymph nodes. So the size, shape, number of lymph nodes and its vascularity are usually checked. Lymph node more than 2.4 centimeters is usually unusual, and even smaller lymph nodes can be malignant if the cortical thickness is more than 4 millimeter. If the FNAC proves it to be a malignant, then axillary clearance is done by the patient. In this case, there may be 29% lymph. But if the cortical thickness is less than 4 mm, then only SNB is done. And this is about lymph nodes, and lymph nodes are always, most of the time, FNAC is done, and sometimes core biopsy is done if feasible. These are the pictures acquired from Buckinghamshire Hospital, Farid's Hospital. The first picture shows the lump of tissue taken out by wide local excision, and peroperative X-ray specimen shows the second picture is showing peroperative X-ray. And in the third and the fourth picture, we see the lesion in the center of the breast lump. And this is the long wire, and this is a hydromark. So it is seen that total cancer is taken out, including good margin clearance. Here also we see the same thing, a hydromark, a wire, the lesion, good margin clearance. This is wire localization done in our hospital, Anwar Khan Hospital, in my department. I am showing the lesion, which we can see in the first picture. These are my hands, and this wire is being located. And in the second picture, we see a very small lesion, which is non-palpable breast mass. And in the third picture, we see through which position we will be inserting the wire. And in the last picture, we are seeing the wire inserted in the breast already. And then the patient was taken in OR, and this lesion was proved to be malignant. And this is the chunk of tissue which contains the malignancy, and we can see the whole chunk, and these are the two wires. This can be also scanned by ultrasound to see if the lesion is within the smart, and if the lesion has free margin, normal tissue all around the mass. So this is also very important, and we are also doing this, going into the operative theaters and scanning this chunk of tissue. And another way of perioperative ultrasound is also we put gel in the surgical site from where this lump has been taken out and in the surrounding areas. If the surrounding areas shows any suspicious lesions, then the surgery goes on until we are satisfied that the surrounding areas are free of any doubtful lesions. So these we have also done in Anwar Khan Hospital with Dr. Sheikh Farid Ahmed and Ali Nafisa and their team. The MDT meetings are usually not here done, but they are done in Dr. Farid's hospital, Wycombe Hospital, and I have attended several of these meetings. This is a very good practice where all the approach, the multidisciplinary approach, are here to discuss each and every cases they have gone through the week or twice a week. The radiologists are there, the sonologists are there, the surgeons are pathologists are there, and the oncologists are there. So it gives a very good scope assessment of the patient and improves the management of the patient, improves survival, and it decreases mortality in 5 years. These are the different guidance approaches. We can see what we do is mammogram, ultrasonogram. This is a solid lesion. This is also taken in my chamber. And this is a core needle in the center of the lesion. This is MRI, and this is the fibroglandular element. These are the fatty tissues. And this rounded lesion is the mass. And this is tomosynthesis, and this thick arrow shows the lesion, which is down below here. So these are the guidance method we screen a patient. Now we will talk about mammography. We usually start mammography in our country, although it's not a standard protocol, from the age of 35 and above, and 2 yearly screening mammograms are done in Bangladesh. Why we do select 35 and why in Western countries more elderly patients are screened? Because this is the reason, because in our country, there's early marriage, early pregnancies, multiple pregnancies, multiple, with pregnancy lactation. So the breast tissue, they lose their elasticity and also lose their fibroglandular elements. And there's a tendency of forming the nodules or cancers in earlier age than in Western countries, because in their country the marriage age is delayed. The patient may avoid pregnancy, and many women they remain single throughout their life. So a 3 yearly screening is followed in Kingdom and many other Western countries. And we have already discussed what mammography shows, and it usually shows microcalcifications and other things. And mammography need not to be scared of radiation because it emits a very small quantity of radiation. And what do we mean by tomosynthesis? It is a very unique technique which shows the lesions very nicely. It's actually a 3D mammography. And will we do mammography in younger patients? Usually no. But if indicated, if the patient is uncomfortable or wants to be very sure or feels a lump, then we also do mammography in patients below the age of 25 years. However, in painful subacute mastitis, breast abscess, and lactating breast, we do not do mammography unless the condition is resolved. These are pictures of mammography and tomosynthesis. The first picture shows a circle with microcalcification. The second picture is the same tomosynthesis with microcalcification inside. The third picture C is showing the thick needle of stereotactic biopsy, and this is the lesion. And the fourth picture is mammography along with tomosynthesis showing the depth of the lesion. However, we are still not doing vacuum extraction biopsies in our country. Although I have heard, I'm not sure, that they have this machine in square hospitals, and nobody is yet using the machine. And in future, I hope to, I have seen many of these techniques while I was in Wycombe Hospital in Buckinghamshire, and it's really unique, and we hope to start this soon as we get the facility. Now, my subject is basically ultrasound. Why is ultrasound the method of choice? Because it is the method of choice because it is readily accessible, it is rapid, it is not expensive, it does not have any radiation, and we use high frequency probes in these ultrasounds, and it has real-time control. Now about the probe, we usually use very high frequency probe, and the probe is nowadays from 11, it has increased to 12 megahertz. So even in large breast or obese patients, we can, with 11, 12 megahertz probe, we can see the very small lesions even in deeper aspects. This is done in my chamber. Here we see the lesion, which has a distorted contour. A core biopsy was done in this patient, and we found this lesion to be malignant. This is a normal picture of breast tissues. I will start from the bottom. This is the lung. This white lining is the pleura. These are muscles of the breastbed. These are the fibroglandular elements, and these tiny, tiny elevations are the Cooper ligaments attachment, and followed by the rounded hypoechoic areas are the fat surrounding the fibroglandular elements. So breast biopsy, there are many, many way of breast biopsies. Most widely used is ultrasonography guided. And as we have said that stereotactic biopsies are still not done, but I've mentioned it because it's done in the Western countries. And sometimes mammographic biopsies are also done. And in cases when there is doubt, uh, there is lesion but not seen in ultrasound or in mammography, then we do mammography, MRI of the breast. And at the same time, MRI, if lesion is found, MRI guided biopsies are done, and a clip is left at the site of the lesion for future follow-up. This is a core biopsy format. Here we will mention the name, age, and date, the finding of ultrasound, diagnosis of breast lump, core biopsy, which breast we mention, and location, the quadrant, the position, and FNSE if it is cystic or any other lymph nodes in the axilla. And usually sent for histopathology or frozen section is done. If found positive, then the patient should be immediately go for ER or HER2 from the same department of ultrasonogram, so the patient do not have to move once to the surgeon, then to us, then to oncologist. So it should be done in one go once we find a doubtful lesion in the breast. So it makes life easy for the oncologist, for the surgeons, for us, for the patients. So it is done from the laboratory, and if the lesion is positive, the patient will definitely go to the oncoplastic breast surgeon, from there on to oncologist, and the multidisciplinary thing will go on. These are the pictures of core biopsy needle. This is a 14 gauge needle, which used in our chamber. And this is the vial where we use with formalin, where we put the chunk of tissue taken by core biopsy. So if we do usually fire up to 8 to 10 fires can be done by core biopsies, and many of the lesions we see. So the floating lesions may, which are partially dipped or sunken into the fluid, may have some malignant tissues or other solid tissues, but which are completely floating are usually fatty tissues. And those which completely sink are usually doubtful lesions, which will be further decided by histopathology. So the advantages of core biopsy over FNSC. Core and FNSC are not done in patients under 24 years of age if the lesions look benign. Usually follow-ups are only done. However, if it looks suspicious, then even with this kind of underage, we may go for core biopsy for breast lesions. Why FNSC is becoming unpopular these days? Because it does not take optimum breast tissues. And so with in optimum, so if the report with suboptimum tissue is done, there's a chance of high false negative reports, which may lead to wrong treatment and wrong surgery. And in these cases, if proven again by core biopsy, a second surgery is required. So we see that FNAC should not be done in cases of solid lumps of breast. Core biopsy is the method of. And FNAC these days we do for aspiration of breast abscess, aspiration of beneficence, and axillary lymph node biopsy if biopsy is not feasible. This is a core biopsy being done in our chamber. This is the lesion, which is slightly lobulated, and the needle is going through right in. And this was histopathologically proven to be malignant, and wide local excision was done in Modern Hospital by Farid and Nafisa's team. These are three images. The first one is a benign lesion. You can see by the homogeneous texture, well-defined capsule. The second lesion is a complex fibroadenoma. However, if we grade by ultrasound, it's going to be like U4 because it is distorted and has heterogeneous texture. But when the histopathology report came after core biopsy, it showed to be a complex fibroadenoma. So, and in the third picture, we see a lobulated lesion, solid lesion with core needle within it. This is also in our chamber. These are two pictures taken in our chamber, which shows intraductal papilloma and intracystic papilloma. In these cases, we will also not go for FNAC and do core biopsy and wait for the histopathological reports. And this is a picture of breast showing severe inflammatory changes or acute mastitis, which is involving both skin and breast tissues. And due to severe infection, there is accumulation of fluid in between the breast tissue and subcutaneous areas, and high vascularity is seen, which is indicative of severe inflammation. This is in our chamber. We saw a pocket of fluid here, and we were not sure what it is. So when we inserted the needle, we found out this thick turbid fluid, a bit reddish, mixed with blood. And this was breast abscess. So in single aspiration, we actually took out most of the turbid fluid, and almost no residual fluid was there. Rest was covered by antibiotics, and the patient did not need further aspirations. But in cases there may be reaccumulation of fluid, we may do multiple aspirations, and in these cases surgery may be avoided in some cases. So cores and FNACs are done in two techniques. One is perpendicular and one is parallel. I will mention one thing here only. In perpendicular technique, there may be overshooting of the lesion. And if the patient is thin, if the breast is small, if the lesion is very superficial, there's a chance of pneumothorax. So in order to avoid this, it is always better to do parallel technique where we see always the needle parallel to our probe. These are different collection techniques, as we have already mentioned. FNSE for cysts, abscesses, lymph nodes, core for solid needles of the breast. And this is the third picture is needle of vacuum assisted biopsy. And fourth picture is excision biopsy. We do excision biopsy when the core biopsy shows three type of lesion. So excision biopsy is taken. It is a B3 type of lesion. This is a schematic diagram showing ultrasound of lymph node and its FNSC. So there are two techniques we do this. One is capillary where butterfly is used, and aspiration technique where directly the needle is guided into the lymph node, cortical area mainly, which is attached to the syringe. A core biopsy needle. A core biopsy needle ranges from 12 to 18 gauges. The higher the gauges, the thinner the needle. The lower the gauges, the thicker is the needle. So 12 is the thickest and 18 is the thinnest. We are practicing cores in our center with 14 gauge needles, and I think it is universally 14 gauge needles still practiced. However, it may vary according to the type of lesion and thickness of the tissues. And this is here, we are doing one core biopsy, the lesion is here. One thing good about all these techniques is we don't need to move a patient for doing cores, FNACs, wire guiding, hydromark placement, a special room, or taking the patient to OT. We can do these in a regular ultrasonogram setup. So this is the bed, this is the machine. We do a bedside biopsy, hydromark insertion, wire localization. And this we did in our chamber. This is the formalin, and this is the chunk of tissue taken out, which is completely at the bottom of the fluid. And later it was proved to be malignant, and wide local excision with other investigation, supportive investigation was done in Anwar Khan Modern Hospital. This is a small video clip. We are doing a core. You can see the needle going right through the lesion, shooting across it, and then cutting it through and taking it back. Yeah. And it was a very successful thing which made us all very happy. Now we will move to hydromark. Hydromark, these are the first picture is hydromark needle. And there are three types of hydromark we usually place. One is open coil, the second is butterfly, and the third is barrel. Usually barrel is mostly used, and these are placed with beginning or along with neoadjuvant chemotherapy. Sometimes 2 or 3 types of coil are used in the same breast or in the in order to see that the lesion which shrinks with chemo is the malignant, and others with the open coil or butterfly may be the benign ones. So sometimes multiple coils are used, and usually one coil is used. The coil remains in place, and with neoadjuvant chemotherapy, the lesion regresses in size. Sometimes it completely resolves. But when we screen the patient from time to time by ultrasound and sometimes by MRI, we always see the coil there, the hydromark there. And then when the time of surgery comes, we put wire in the site of the hydromark, and then the patient is taken to OR for operation by wide local excision. This is a placement of hydromark done in ultrasound center. I am helping Ali Nafisa to put the hydromark into a solid lesion. Although the lesion looks very nice ovoid shape with good margin, um, but due to age, due to the patient of the age, which was more than 55, we inserted this hydromark, and the lesion after core biopsy was found to be malignant. These are still pictures of the same. This is the needle inserting into the solid lesion, releasing the hydromark here. And this is the hydromark which will stay within the lesion. And then with neoadjuvant chemotherapy, the lesion will shrink, is supposed to shrink or will shrink. But the hydromark we will follow by ultrasound, usually by ultrasound and sometimes by MRI. So these have all been discussed. These are implanting markers, and actually the calcifications are here, which are not very clearly seen in these pictures. So I'll skip. These are the pictures which I have taken in Wycombe Hospital while they were doing vacuum assisted biopsies. And since we are not doing this, I'm just showing you a few pictures here. I was in this room while they were doing this. This is the mammography of the breast, and this is the lesion with needle into the lesion. And these are the cuts. Usually with vacuum assisted biopsy, 12 cuts, approximately 12 cuts are taken. And then immediately X-ray is done in the same room to see if there are calcifications within the lesion. Now we will come to MRI and CT. With MRI, we use a powerful magnetic field which gives us details of the insides of the breast. And advantage is radiation free and disadvantage is expensive. However, we do have to use MRI in cases where there's still doubt of a lesion inside the breast. However, mammography or ultrasonogram may not pick it up. And as we have mentioned before, MRI guided biopsy may be done and marker clip is left in situ. And this patient is followed up by MRI. Now, why wire localization? We use two types of, in fact, three types of wires. One is short wire duo, and other two are longer wires. One is 7.7, other one is 10.7. So the short wires is a hook pattern which is very stable and does. But in cases of deeper lesions or in obese patients or large breasts, we have to use the longer wires. And the longer wires will have a clip at the skin surface of the breast, so it does not move away from the site. And the short wire, due to presence of the hook, it usually don't move from the site of the lesion. These are pictures of the wires. This is a long wire, and we see here a hydromark, and this is the lesion. This is a hook wire, a short one, and this is a hydromark. This is the lesion, and this is another hook wire, hydromark, and silicone implant within the breast. So after confirmation of by core biopsy, staging and everything, wire local excision is done by the oncoplastic surgeon immediately after wire localization. This is in our Anwar Khan hospital along with breast care unit. Here I am showing Farid the lesion, and this was followed by wire localization and taking the patient to OR. Here is the breast team along with me. So what should be done in practice, whether it's benign or malignant, ultrasound guided core biopsy should be done for all types of solid lesions. In cases of microcalcifications, and if there is architectural disorganization, and if there is microcalcifications along with ultrasound nodule. In all these cases, ultrasound guided core biopsy is done. And post biopsy management, if these different criteria, we have some of the risk of underestimation is less than 10%, and percutaneous ablation or close monitoring can be discussed. Finally, for carcinomas, surgical revision is essential because tumor remains can persist even if radiological abnormality has completely disappeared. So what will the report say? The size of the lesion, appearance by BIRADS clarification, clock wise distribution, and its distance to nipple areolar, implantation site of the marker clip, guidance technique, and all these things. So in summary, breast imaging has highly improved the capability to provide histological diagnosis of non-palpable breast lesions of percutaneous needle biopsy with variable and increasing numbers of options for biopsy of breast lesions. Careful attention must be paid to the selection of patients and types of lesions of different procedures. Thank you. Nafisa?
Yeah, madam. Madam, hello.
Yeah. So I've concluded.
Thank you, Dr. Humaira Islam, madam, for her nice presentation. Before going to question and answer session, I want to mention that lots of our seniors sir, like Mutiur Rahman sir, Mujibur Rahman sir, Dr. Shifan from Maldives, Dr. Muhyuddin from Canada. Can you hear me? Anwar sir, Rafiqul Salehin sir is there. First of all, I would like Dr. Mutiur Rahman sir to invite. Dr. Mutiur Rahman sir, are you there? Can you hear me? Hello? Okay. Muhyuddin sir, hello. Assalamu alaikum. Assalamu alaikum, Muhyuddin sir. Can you unmute yourself?
Walaikum salam.
Thank you, sir, for joining with us.
No, thank you.
Sir, please,
I'm
first
enjoying.
of all,
Thank you.
introduce yourself, please.
Assalamu alaikum. I am Dr. Mohiuddin. I am from Canada. I'm a radiation oncologist here.
Alaikum Muhyiddin bhai.
Walaikum salam.
Thanks for joining.
I would like to invite Dr. Shifan from Maldives. Hello, Dr. Shifan. Shifan,
Hello,
Mohammed Shifan.
hello,
How are you?
hello. Assalamu alaikum. Welcome, salam alaikum. I'm doing well. I'm from Maldives. I'm a surgical oncologist from Maldives. It's really nice to be here, and it was a very, very enlightening presentation. Yes.
In 2018, the second ASMO conference, Mohammed Shifan organized, and that was very nice program. Thank you, Dr. Motiur Rahman sir. Can you hear me? Are you there?
No, thank you. Thank you.
Thank you, sir.
Thank you. Thank you. I'm enjoying
Sir,
the talk. Thank you. Very good, Nafisa.
thank you, sir. Your
Thank you.
presence encourages us lots. Dr. Salim sir, please, can you add something?
Assalamu alaikum. Thank you. I am all the time here, and basically I was enjoying the session. It was very descriptive and very clear.
Thank you.
Thank you, sir. Professor Mujibur Rahman sir, please, sir, are you there?
Yes, yes, I
Yeah,
am here.
thank you, sir.
Well, Nafisa, I'm enjoying the whole program and so many things which I wanted to know from you, and you are clearing those things. And there has been a lot of advancement in this subject. So please continue with the program. Thank you.
Thank you. Dr. Anwar Khan, Anwar Hussain, sorry, sir. AFM Anwar Hussain, sir, please.
Okay, thank you.
Yes, sir. Assalamualaikum, sir.
Salam. A lot of thanks to Dr. Farid and also to you in this program. And there are further few question session. I think I would like to see viewers after the ending of the question session. Thank you. Go on.
Okay. So now we want to start our question and session.
Nafisa, would you like to invite our respected faculties to say words or comments before you go to a QA session?
Okay, okay. First of all, I want to invite Professor Shivandu Majumdar sir to say something. Sir, please yourself, sir. Shivandu sir, unmute yourself, please.
Nafisa, যিনি কথা বলবেন তারা সবাইকে মিউট করে দাও। ব্যাকগ্রাউন্ড নয়েজ শোনা যাচ্ছে plenty.
Shivandu sir, please unmute yourself. Shivandu sir, we can't hear. Unmute yourself.
শোনা যায়?
Yes, sir.
Yeah, okay.
Yes,
thank
sir.
you a lot, Dr. Ali Nafisa and Dr. Humaira Islam, consultant radiologist, Anwar Khan Modern Medical College and Hospital, Dr. Farid Ahmed, oncology surgeon and general surgeon from UK, and I am seeing our respected teacher Motiur Rahman sir there, and all legendaries present here. It's a nice session, and I am grateful to you for inviting me here and to say something. Dr. Humaira is a renowned sonologist in Bangladesh. Everybody knows it. And nicely she prepared the lecture presentation as well as delivered in toto. So we are grateful to her, and knowing the different systems and modernized technique for interventional radiology, and in collaboration with the surgeons, we can help the surgeon as well as the patient for the betterment, and we can guide even the unculpable masses and very early stages the culpable masses, and for margin clearance. as Dr. Humaira told. So nothing to say. So I have one question. Usually the metastatic lymph nodes, yes, cortical thickness may happen. Usually in case of metastasis and tuberculosis, hilar echogenicity is lost and it become hypoechoic and uniform. So it is one of the sign of metastasis. So thank you again. And now a lot of radiology and imaging is advancing, and interventional radiology is enormous developed in the abroad, though we are lagging behind, and we are trying to catch the tail of them. So thank you again, everyone, for giving me the chance to say something. Thank you.
Thank you, sir. Sir, I would like to invite Dr. Professor Kamrujaman sir to say something. Sir, please unmute yourself, please.
First of all, I should thank, we had among with us the senior professor and our teachers like Professor Muthuraman is along with us, and a lot of senior surgeons and radiologists and students are there. Definitely, I should thank Farid because he had made things happen, especially the newer technology where we can use these wire localized, especially in breast cancer. Mammography, ultrasono, and with these modalities, the MRI, with these modalities, how we can make a best treatment efforts in terms of breast cancer management, especially like neoadjuvant therapy, how we can locate the tumors after neoadjuvant or a couple of cycles, how the surgeon will locate. So this wire localization and also the hydromarker has revolutionized, especially in terms of neoadjuvant treatments in the case of breast cancer, where BCT can be done, where organ can be preserved. And recently, the TNBC, triple negative breast cancer, is always treated with a neoadjuvant therapy. A total course has been given, chemotherapy has been completed, and then surgery has been done. So in that cases, how they will locate the tumors if they doesn't put any wire or any hydro marker there. So 30% of the breast cancer is coming up with a triple negative. So a lot of improvements have been done with newer technology. And I should thank especially Dr. Farid, who has trained the sonologists and also the oncosurgeon, breast surgeons, to make this happen in Bangladesh for a couple of years, especially. And regarding the lectures, Humaira is excellent. He is an institution regarding the sonology, actually. I know him very beginning, especially after graduations, we know Humaira. I am confident he's a very good sonologist, and even he started the newer things that is going on in Bangladesh. So this is a newer technology where they started in Dhaka cities, and definitely it benefits the patient, especially in terms of TNBC. I like it very much because TNBC cannot treat the patient with the surgery. Even the tumor may be small, but you will have to put the clips and wear other things, get the chemotherapy, complete the chemotherapy, then do the surgeries. So in that case, it's excellent things what we are getting in Bangladesh with these teams. And definitely Humaira has nicely briefed everything like mammography, ultrasonography, wire localization, CT and MRI, everything has been teaches in this short 45 minutes. I am impressed about his presentations. And really, I thank to both Farid and Nafisas and Humaira for their teams. Thank you all. And Mohideen is there from Canada. He can add something.
Thank you, sir. I would like to invite Dr. S.K. Farid Ahmed, sir, a British oncoplastic breast surgeon who is the man behind this whole scene and invents this lot of things in Bangladesh. Please, sir, please add something.
Excuse me, can I ask, make a comment, please?
Okay,
Of course.
So Thank you, Dr. Humayra, for your nice presentation. But one question is here. I believe this multidisciplinary approach and one-stop service you're doing in Anwar Khan Medical College or private sector. So I have a question about medical college setup in Bangladesh. Like I can see there is head of radiology from Sharwardi Medical College, I believe.
Yes.
Yeah.
So
Yes.
in your college, do you have any setup like, who is doing the biopsy for the breast?
Yes. Our radiologists are doing the biopsy for breast. We have trainee doctors, we have teachers, including me. We all do the practice.
I think that should be the norm, because most of the time breast cancer patient in Bangladesh, they are lost. When the breast cancer diagnosed, someone have lump, most of the time I saw in Chittagong patient going to see gynecologist, and gynecologist then do something else, then patient go to surgeon, then some surgeon do the lumpectomy or mastectomy or whatever without any biopsy, and then there is no organized program, I think. So we should start doing it the way Anwar Khan Medical College is doing, that they have, it looks like they have a good breast care program or breast health program. So this is the time we need to think about national breast health program. And I think that thing already initiated by one private group, but in government medical college, if we do not do it, then the program will not see the success, and breast care, we are not going to see the proper breast care. And Humaira mentioned about multidisciplinary approach. This is very, very important. Without multidisciplinary approach, and if breast surgeon do the excellent surgery and everything is done, but if there is no multidisciplinary approach and no connectivity with the other group, then it will, I don't think it will see the success. So when I see my patient here, we have a very good program called breast health program. Patient initially have the screening mammogram, and on the screening mammogram, the very same day, if there is any suspicious lesion, very same day, they keep some slot for diagnostic mammogram and ultrasound biopsy, and very same day they do it. And immediately from there, they send the patient to surgeon and radiation oncologist and medical oncologist. And at the same time, each program has a breast care navigator. Breast care navigator is a post, is run by a nurse. So navigator always navigate the patient and direct the patient where to go, which appointment she must go first and which one after that. So I think it's time for Bangladesh to think about this kind of program. And as a physician, we should initiate this program in each specific medical school or medical college. Otherwise, nobody will do it for us. And someone must take the ownership to start the program the way in Anwar Khan, initiated by Dr. Farid and Ali Nafisa and Humaira. And in other medical school or medical college, they have to start this kind of program, and they can, collaborate each other. Thank you.
I think a very good suggestion Mohiddin has given, actually, because we had a lot of medical colleges in Bangladesh, and also all the medical colleges has some sorts of oncology departments and very good imaging departments, and then they can start with especially the tumor board and other things, and they can start. And I think the National Cancer Institutes, what we have in Dhaka cities, that should initiate this type of imaging and other breast, what we have telling about the breast clinics and other things that we can start in national cancer centers. And even the government has taken 8 regional cancer centers that should be incorporated in that. I think the radiological societies and oncology society, they should I think they should plan in that way. There should be a breast clinic and other things where the breast cancer patient or breast disease patient can be navigated, like what you are doing in Canada and US and other places, and also in UK.
Thank you, Muhyiddin.
Excellent.
Jaman sir, I would like to invite Dr. Farid Ahmed sir to say something before next we will go for a question session.
Thank you very much, Nafisa. Well, at the outset, I'd like to express my respect and gratitude with all the respected dignitaries and senior professors and all my colleagues, those who have joined to listen to Omar Appa's excellent talk. She's been basically an institution on herself, and the knowledge and expertise she has got, which I have experienced working with her for about 2 years or so, is simply amazing. And she continuously likes to develop herself, and she visited UK and learned a lot of new things here from the breast unit. And I believe she is planning to visit further to develop some more radiological skills acquiring that will eventually help Bangladeshi people. And hopefully she has a plan for setting up institute. And I'm sure many young sonologists and radiologists would benefit from her. But what Dr. Mohiddin Bhai said was an absolutely important point. And it is also important that the vast majority of the healthcare service are provided in private sector in Bangladesh, I think probably 60-40 percentage wise. So government hospital needs to develop. At the same time, private sector needs to develop, and we need to develop together. But more importantly, government has to come out with some ideas of some national screening program. And at least it can be started at a central level and can be gradually be expanded. And that's where if you could identify a cancer early and through breast screening before it is palpable, because there is a general concept. I know it's in subcontinent, it's quite commonly thought that screening means a medical officer would be sitting in a village area, just feel the breast with the hand, and if they find a lump, that's called breast screening. But actually, that's not the true essence of breast screening, because the concept of screening is to identify a small lesion, you treat them early, you get the best benefit, and eventually it will have impact. I mean, we know from UK, from 30 plus years of introduction of screening, we have seen the mortality have significantly gone down, a big percentage, 25 to 30% have gone down, and it's because of early diagnosis. So in Bangladesh, I think time has come at government level, they have to have some sort of discussion to set up breast screening program at national level, maybe starting with all the government hospitals, at least to begin with, supplying all this digital mammography, 2-view mammograms could be done, and local people could be invited, even 3 yearly basis, if they cannot make it 2 yearly. And if they cannot make it 35, even if they start from 40, I don't mind, but they have to start at some point. And this is high time. I mean, we are often claimed that we are developed so much that we are comparable with developed countries, which is fantastic. But as far as health sector is concerned, we've got only 1% GDP allocated. That is a big problem for us. This is like an immediate non-starter. Well, I don't want to go too much details with all these issues national level. I think it is absolutely important that we start from ourselves. We start to develop ourselves as a one person, as a clinician, then as a unit, and then as an institution, and then local, regional, and national level. I think development has to come at all level. And one thing I have to say, often I see in Bangladesh and other parts in the region, patient comes with a breast lump, they get a FNSC, and FNSC shows cancer cells, and straight away surgery done. And this is an absolute no, because we haven't got the immunocytochemistry, ERP or HER2, as Professor Kamrajaman Bhai quite rightly said, that triple negative cancers, or ER negative, HER2 positive, or simply ER negative, or very aggressive large grade 3 cancers. There could be various permutation combinations. These sort of cases would have very good response from chemotherapy first, and then we could do surgery. And that would eventually benefit patients, because unnecessary mastectomy has got a significant personal, social, and psychological negative impact. And even in European countries, you see huge number of divorce, separation takes place after cancer surgeries are done. And Bangladesh and the region is no difference either. So we have to avoid unnecessary over treatment, over surgery, simply breast conserving surgery that can be done, and where a multidisciplinary team approach, a good radiologist, a sonologist can make a big difference to a decision making as a part of within the multidisciplinary team. So what I was trying to say is we do need to get our basics right and do our things right at the first time. This is the absolute key thing for ourselves to develop, that we should actually do, after taking history examination, do basic images like a mammogram to begin with. Often this is taught in Bangladesh that a palpable lump, if it is a cancer, do not need a mammogram. Please, I beg, this has to stop. This sort of teaching has to stop, because that's not internationally recognized teaching, and that doesn't help our patients as well. And we have to stop this sort of education. So what Humara was eloquently, very precisely have presented the stepwise needs, the patient journeys is absolutely brilliant, and we should practice this for our patients' benefit, for our country's benefit, and if we change our practice, it will help our patients. I think in that point, I would like to thank you all once again for joining, and I will pass it over to Nafisa for QA sessions to start. But thank you very much once again.
Thank you, Dr. Farid Ahmed sir, for your speech. Now I'd like to ask Dr. Aksa Khan. Are you there? For your question. Hello? Aksa Khan, please unmute yourself and ask your question. Okay. I ask, what are a finding of size and shape for malignancy in axillary lymph node? Dr. Humara ma'am, please. What are findings of size and shape for malignancy in axillary lymph node? Dr. Humara ma'am.
I have already discussed that. I would like to repeat the same thing. We usually examine both the axilla, the axilla with breast lesion, and also the opposite axilla. Here, the number is not very important, but it may be a single lymph node, it may be multiple lymph node. And two things are very important. There's change of shape of the lymph node. The lymph node normally is ovoid to tubular in shape, and when there is metastasis, the lymph node becomes more or less rounded, and the texture changes to hypertrophic, and we see corticomedullary differentiation. However, the cortical thickness should exceed more than 4 millimeter for suspicion of malignancy. Then FNSC is to be done, and if feasible, core biopsy is done for lymph nodes to see if there is metastasis of the lymph nodes, or whether the lymph nodes have got any other secondary metastatic disease, or whether other diseases like lymphoma cause increase of, and the changes are more or less similar. Changes are more or less similar. We have to keep track of the cortical thickness. 4 millimeter.
Can I politely request everybody mute, apart from the person who is asking question and the faculty, respected faculty member who is answering, and rest of the attendants, please mute yourself. There's a plenty of background noise. Thank you.
Am I clear? Do you want me to say anything else?
Dr. Mahmoud Hassan, you raise your hand. Hello? Dr. Mahmoud Hassan, you want to say something? Hello?
নাফিসা, আমি একটু বলতে চাইছিলাম পরে।
Yes, sir. Ji, sir.
Yes. Thank you for giving me the mic. I have some comment. I am Professor Mahmoud Hassan, retired from Sarwardi Medical College, now working in a private medical college. We started breast diseases and also cancers from 1985. Then there is no facility of ultrasonogram and other things. Now days are advancing and the technologies are advancing. I enjoyed the Humara's deliberation and Nafisa. Thank you, Humara and Nafisa. I want to add two things. We think breast cancer as a systemic disease from the very beginning, number one. Number two, triple assessment is mandatory for diagnosis. In our country, and even in the developed Western countries, usually patient comes in the late stage. One of my colleague and also friend, his wife is also a doctor, presented in USA with advanced cancer and she died. And our colleagues, also professor, in our country, they lost their wife due to breast cancer. So, so the early diagnosis is very necessary, and core biopsy is good, very good. FNAC sometimes gives false negative and false positive. So core biopsy, I appreciate it, and it should be multidisciplinary approach to treat the patient. And you usually consider breast cancer not 5 years, 10 years. After 10 years, also there is some metastasis in the bone. So you have to follow the patient for 10 years. Thank you all.
Thank you, sir. I would like to invite Dr. Rafiq Salim, sir. Please, you want to say something?
Yes. First of all, thanks to the organizer for organizing such a nice session. Thanks to Dr. Farid, Dr. Ali Nafisa, Dr. Mohuddin from Canada, and my senior teachers. That was a very lovely discussion, but I want to focus some of the points which was discussed here. So nowadays, it is very clear that we have to reach a very pinpoint, clear diagnosis before taking any decision. And that is a collaborative decision, interdisciplinary collaboration between the radiologist, between the oncologist, between the breast surgeon, breast nurse, pathologist, everybody. And only one thing is lacking in our country, that is the collaborative effect. And basically, we do not have any national guideline. I was been in UK and I worked there. They have, NHS have got their very clean cut guideline. This is the way you have to run. But again, in the country, the academic institute, we are running with some guidelines. That is, nobody is not doing any breast surgery without any histodiagnosis. Everybody is doing the breast surgery after getting the core biopsy or tissue biopsy. That is a very prime. And mammography, and when needed MRI and everything. And we are doing ER, PR, HR, KI67, proliferative index, P53, all these things. And we are then collaborating with our medical oncologist and radiation oncologist to set up a point in the, at least in the Dhaka city. So this is our present time protocol. So don't get any misunderstanding about the nationwide treatment. So we are following, definitely we are following some of the guidelines, which is a, world standard. And Dr. Kamruzzaman Bhai is very much here. Sometimes we communicate with him for select our individual guideline for the individual patient. And I must say, which is very vital, breast cancer treatment is very much individualized, and the particular treatment will be suitable for that particular patient, taking all of the reports in my hand. I attended a session in the last session, American College of Surgeons in the San Francisco. And some of the North American people, they were just presenting the case, and they said that they can cure the breast cancer only with radiotherapy. Brachytherapy, some implantation radiotherapy. And I was astonished. They are trying to taking the knife from the hands of the surgeon. So breast cancer treatment is a controversy. If you think it's a controversy worldwide, but definitely there is some definite protocol, and that is we are following and everybody is following. I think that was my view, and we can discuss whole of the day and nights with the treatment modalities, which one is fast, which one is last, which one we have to continue. But again, we'll follow the guideline. We'll not cross the upside or downside of the guideline, which is total world is following. So thank you very much, Alina Fisa, for giving me opportunity to say few words. Thanks again.
Thank you, sir. I would like to say something. Dr. Jaideep Bhaduri from Rajshahi. Sir, can you hear me? Dr. Jaideep Bhaduri. Hello? Dr. Jaideep Bhaduri.
I can also see Professor Mannan as well, kindly joined us.
Oh, Dr. Mannan, sir. He is our team, anesthesia, professor of anesthesia. Please, Mannan, sir.
আচ্ছা, আমি ঢাকা মেডিকেলের প্রফেসর সাহারা কেও দেখতে পাচ্ছি, রেডিওলজি ইমেজিং এর প্রফেসর।
We will ask one by one, সবাইকে. Nafisa, could you do that?
Dr. Mannan, sir.
Everybody for the comments.
Dr. Mannan, sir. Can you hear me? Okay. Professor Shahara ma'am from Dhaka Medical College. Dr. Shahara ma'am from Dhaka Medical College. Hello. Shibindu sir.
হ্যাঁ, ডক্টর জেরিন বললে আমি দেখতে পাইছি ওকে। ডক্টর জেরিন, প্রফেসর জেরিন।
Professor Jerin ma'am from Dhaka Medical College. Hello. Can you hear me? Professor Jerin ma'am from Dhaka Medical College. Okay. Can we start the question and answer session again?
Sure.
From chat box. Anwarul.
Alina Fisa.
Yeah, ma'am.
I would like to say something.
Assalamu alaikum, ma'am.
No, Shubhal Chandra Paul.
Yes,
hello.
Yes, sir. I would like to say something, Dr. Alina Fisa.
Thank you, Bhaiya. Bhaiya, please sound low, please.
I would like to, at first, I would like to express my thanks and gratitude to Professor Farid Ahmed sir, Moti Rahman sir, Rafiqul Salehin sir, and also thanks to the organizers. And thanks to Ali Nafisa, my beloved, to give me opportunity to say something. Actually, Professor Humayra Madam, a renowned sonologist in Bangladesh, and we all know her very well. She's doing many innovative things for Bangladesh, and actually she is running the Bangladesh forwards. I would like to say another thing, just some compliments to Muhammad Mohiuddin from Canada and Mahmoud Hassan sir, AFM Mahmoud Hassan sir. Actually, early diagnosis is the mainstay to give something to the country. Advanced stage treatment, actually advanced stage treatment actually can give something, but many things is possible by early diagnosis. For early diagnosis, referral system is very important. Without a referral system, we are not able to get any patient.
Yes.
A lot of patients in Bangladesh, but we are not getting that patients to do something for them. They're coming to us in advanced stages. How can we get patients at an early stage? This is the way. It is not the policy of the doctors. It should be the policy of the country, policy makers, referral systems. I know many doctors in Bangladesh, many surgeons in Bangladesh are adequately knowledge and skilled, but they are not able to apply the knowledge and skill to the patients. Actually, our knowledge and skill is going in vain. If our country can do something, can make a system only then this knowledge and skill can be utilized. Otherwise, this knowledge, these skills will go in vain. Thank you. There are many policy makers in this forum. They can talk with the system policy makers and they can do something for the early patients. I know many doctors in Bangladesh and they have got mentality to do something, but they are not practicing. They are not able to practicing. Thank you, sir.
Thank you, Shubal Bhai.
Just one compliment line from Subos. So Dr. Subal, it was a very nice to talk. But again, Dr. Farid is doing the things. It is not the Boris Johnson who is arranging the everything. It is you and me. We have to organize all of these things. We have radiology department, we have pathology department, we are ourselves, have our knowledge, we have our histopathology department. It is you and me who have to initiate, who have to do the procedure, and stereotactic biopsy, clip localization, everything is, you know it. And it is not a very difficult job. It is not a very tough job. It is a very simple thing. And I used to do the stereotactic biopsy back in 1997 and 98 in UK. Just you put a guide wire and just localize it, excise it, and take the biopsy. So that is a very simple thing, everything is. But you have to practice, and me, I have to practice. And we are the core body. We have to take our things forward, not our honorable PM or not our honorable president. So thank you, Subal.
I
want to add with Professor Dr. Rafiqul Salehin. Yes,
sir.
It is by the medical college, it is by the organization itself, not by the government. Our Mahmudul Hassan sir is also here from Shahid Sohrawardi Medical College. We are now developing individual medical colleges, interdepartmental relationship, then it will develop. So individual center should take part. As for Dr. Farid, Kim, and Dr. Humaira and Nafiza is guiding, and ultimately in a non-government medical college, it is possible. So government medical college is also rich in resource and manpower. So why not? So it is our duty to arrange this, not by government. In government, there are many in coordination, as we see in the COVID-19. But in our hospital, we should take forward. Thank you again.
I want to add one sentence, please. Can I?
Yes,
Can
sir.
I do agree with the Salehin. There should be a national protocol. Everybody is dealing with breast disease. So there should be a national protocol. Our sir, Ghulam Rasul, started and tried very much to make a national protocol, but it was not completed. The young surgeons and now the senior surgeons and doing in government job, just like Rafiq said, they should start for this national protocol, as because the breast diseases are maltreated in our country nowadays. Thank you.
I would like to say a few words, Dr. Nafisa.
Yes, sir. Yes, sir.
Please.
Please, sir.
It is for kind information to all of the panel of experts and the faculties, both from national and international level. Actually, in response to the question raised by Dr. Mohiuddin from Canada, today in Bangladesh, no surgical intervention is done without doing FNAC or core biopsy.
Exactly so.
As because just 2 years back, I was in National Institute for Cancer Research at a departmental head in surgical oncology. So So far, I know till today, the breast diagnosis having a lump is done by the surgical oncology department, the medical officer up to the assistant professor in their own hand with the help of sometimes the radiology department. So without doing appropriate diagnosis, no patient treatment is going on. In that scenario, the which you have mentioned before, this is not prevailing, though there are few rare cases in different corner of the country. But in an institution like National Institute of Cancer Research and Hospital in Mohali, Dhaka, the situation is very nice, and there is a medical board, there is a breast unit where each and every patient having breast disease evaluated both by the surgeons and the oncologist, and multidisciplinary team decision is giving whether neoadjuvant chemotherapy is needed or go for surgery or whatever may be. But only one thing is left behind, that is the use of hydromark till today. This is the important issue. And in this regard, I'd like to give thanks to the heartiest thanks to Dr. Humaira and the Ali Nafisa and Dr. Farid for inviting this important issue in this regard, to use hydromark in locally advanced disease before neoadjuvant chemotherapy. This is one thing. Another important thing, the use of wire-guided localization of the lesion following neoadjuvant chemotherapy and in case of non-palpable lesion. So this is the help needed from the radiology department all over the country. So we are in a very primitive stage, but still then the approach to handle this type of malignant disease or breast disease is going on very perfectly. So thanks a lot to everybody.
Sir, wire guide is actually needed prior to surgery. Prior to surgery to give information about the impalpable or very early stage of cancer.
Amrujan bhai, and please unmute yourself.
Yeah. Can I add just one thing? Because I was in head of national radiation oncology departments of National Cancer Institutes in Mohakali. If you see the data of the 10 years of National Cancer Institute, you will see in breast cancer, stage 3 and stage 4 patients are more than stage 1 and stage 2. And definitely that patients got chemo and other things, and the mortality is high than the American and European studies. If you see the last year study, surveillance epidemiological end result study of the USA, last 37 years, they showed that there is a trend in mortality of the breast cancer in USA in all centers because due to early diagnosis, early stage, and modern technology of management. So as we are having the advanced stages, so we are definitely, our mortality is high, we are getting the advanced stages. Scenario will gradually change. Gradually, definitely, early cases will become, in urban cases, we'll get early cases, but in the village and other things, actually we are not getting the early cases. So we'll have to educate the people, and there should be screening procedures gradually, and we should have some plans from every institute, like Professor Salihin, what he's telling. We have started, similar National Institute Medical College should start, and gradually everybody should be incorporated in these settings.
Brilliant. Brilliant.
Actually,
I'll just take 30
I
seconds.
want to add something. Actually, there is no referral system. There is no referral system. That's why no system of the sonologist also. We are seeing the sonology for 10 days or taking training for 3 months and doing the sonology by China machines, processing 3 lakhs rupee. And not only that, they are doing breast imaging by putting the saline bed and giving the report. Ultimately, how you will get it in fastest. Therefore, in the last stage, it goes in the tertiary center. And that's why national policy is also needed. Sonology is doing everywhere, every person. Everybody is sonologist. Sonology is not a very easier subject. It is difficult subject. And machine, man behind the screen is very much
important.
important.
I absolutely agree with Shivendu sir. National system must be there.
Yeah.
For a good service.
Yeah.
National guideline and system also must be there. And one thing is,
even the older medical college does not provide mammographic machine, but nowadays provides high resolution ultrasonography machine, purchased but not acted.
May I just take 30 seconds?
In this regard, hello. In this regard, I would like to say one thing.
Professor Mahmood Hassan, sir, please.
Yes,
another thing, it is not mentioned, it should be mentioned, self-assessment, self-examination of the breast is also an important procedure. It is not mentioned, so I like to mention it. Yeah. Self-examination of the breast.
Thank you very much. Professor Anwar, please.
I would like to say another important issue is because a lot of discussions has already goes on regarding the national policy. Actually, I do not like to disclose this. Till then, I want to say, as a Secretary General of Association of Breast Surgeons of Bangladesh, as because I am bearing that post, that is why I would like to say that we have already did a national guideline for breast disease or breast cancer management. So it will be come out after the approval of the health ministry. We have already completed and there are 2 subsequent meeting has already been done. Final approval, we are waiting from health ministry. Only then that guideline will be disseminated throughout the country, initially to all the medical colleges and then the district level hospital. Thank you.
Thank you, sir. Here, Professor Shahadat Sheikh, sir, is here. I would to like invite Shahadat Sheikh, sir. Please unmute yourself and say something, add something.
Oh. Okay, thank you very much. Thanks to the organizer. Actually, it was a wonderful session. I participated, and special thanks to Dr. Humaira for her wonderful presentation. And nowadays, I am not practicing this breast disease, but still the presentation was so nice. I have taken some screenshot from that without permission, with proper permission from Dr. Humaira. I have a very simple question about the measurement of the cortical thickness of the lymph node. You mentioned you have taken in consideration when it is 4 millimeter. So do you consider the 4 millimeter cortical thickness only in breast carcinoma and lymph node, or the other carcinoma associated lymph node? Is it particularly for the breast carcinoma or in the other carcinoma as well?
Breast. Humarapa, please unmute and answer.
Breast.
Madam, please unmute yourself. Madam.
It is particular for breast.
Okay. Okay. But at the same time, you consider the other criteria of the malignant change of a lymph node, like the shape of the lymph node and the echogenicity or heterogeneity, whatever you say. You consider only you consider the cortical thickness.
Not the cortical thickness. Actually, the shape, the oval shape or elongated shape become rounded. And the hilar echogenicity is lost in case of metastasis. It is very important. And size is also not important.
Hilar
a smaller size with loss of hilar echogenicity is suspicious to malignancy.
Okay, so you consider the multiple things.
Dr. Subendu, hilar echogenicity is lost in most of the cancers, and in breast cancer, we mainly consider the cortical thickness.
Yeah, I
Okay.
And hyaluronic is lost in, like, you can say lymphoma, you can say others, other
yeah,
cancers,
tuberculosis
Yes,
also, tuberculosis also.
tuberculosis, yeah,
But if I get mass together with the lymph node with loss of hilar echogenicity, then it is valuable.
then it is valuable for any kind of malignancy. So we screen not only the breast, but for other areas to search for malignancies, like head, neck,
Yeah.
ENT problems, arms, other parts of the hands, chest. So they can all change the hilar echogenicity, but for breast, cortical thickness is very specific.
Thank you. Thank you very much. I think
There,
there should be much question and answer, and there are a lot of questions. Probably that is better to go at that session. So thank you very much. Thank you for it. Thank you, Nafisa and the Dr. Humaira and Shivunduda. Thank you.
Thank you. Thank you, Shadway.
I would like to Jasmine Arifin Mili, if you hear, or I would to read. Patient having hydromark, and after taking NSC, her lump size was reduced. She wants to wait, then how long patient wait for surgery?
Can I answer that?
Patient having hydromark, and after taking
No,
NSC,
I heard that.
is reduced. She wants to wait, then how long patient wait for surgery? That means she also asks the how long wait for surgery from last NSC chemotherapy.
Yeah, I think I have answered that already, but since you have raised it, it's more of a medical need. Body needs to recover from the chemotherapeutic, all this leukopenia and also some other immunosuppression. So what we recommend ideally is 4 weeks average post neoadjuvant chemo, then we offer surgery. This is what we practice in UK, but it can vary. It could be 3 weeks, it could go up to 6 weeks, but we do not recommend it for too long. But ideally, average is 4 weeks after completion of neoadjuvant chemo.
Thank you, sir. Saiful Anwar, are you there? Is Birod's classification and scoring only applicable for mammogram? Dr. Shubhendu sir, please answer this. Please unmute yourself.
Yeah, again mention the question.
Is Birod's classification and scoring only applicable for mammogram?
No. BIRAD is mainly in ultrasonography, then in breast mammography, and also PIRAD in case of prostate, and MRAD in case of cardiac. Now, radiological reporting system is this. And your 0 to 6, grade 0 to 6, BIRAD system in case of ultrasonography in the breast and also in the mammography.
Madam, please unmute yourself.
BIRADS is, of course, from 0 to 6. And as for 0, it is incomplete assessment. For 1, it is negative. For 2, it is benign. For 3, it is indeterminate. And for 4, it is suspicious. And for 5, it is established. And sometimes for 6, already known.
Proven
that is
case.
mammographic classification. For ultrasound, we use the same thing, but we use the term U. And for chemotherapy, you use the same thing, cytology, sorry, where we use the term C. So ultrasonography uses the term from U0 to U6. And BIRADS or mammogram, M0 to M6 or M1 to M6. BIRADS similarly from BIRADS 1 to BIRADS 5. And the cytology from C1 to C5, and ultrasonography from U0 to U5 or 6. So BIRADS is more or less mammography related terminology.
Thank you, Humana madam, Farid sir, hello.
Farid, I would like you to highlight on this, please.
No, the answer is already given. Thank you. I think Professor Shibandu and Umarappa, you already have answered it. And we use a typical terminologies from 1 to 5. If P means palpation, P1 to P5. So anything 1 is normal or maybe missed. 2 is benign, 3 is indeterminate, 4 is suspicious, 5 is malignant. If it's a mammogram, we grade it as M1, M2, M3, M4, M5. Same 3 goes for ultrasound, U1 to U5. And if it is cytology, C1 to C5. But if it is C1, which doesn't mean it's normal, it means it's inadequate sample, needs a repeat. And if it is a B1, which could be normal breast tissue or missed the lesion, and then anything B2 is benign, 3 is indeterminate, 4 suspicious, 5 is malignant, and B5A is DCIS, and B5B is invasive. So that's how we grade, like a unified grading from palpation, cytology, biopsy, mammogram, ultrasound, everything as 1 to 5. But BRAS is used as far as breast density is concerned, and BRAS 1 to 6 is used. I think Professor Shivandu has eloquently explained that it is mostly breast, but it can be used for some other as well, which I'm not very much aware because my expertise is breast. And obviously, Humayra has already explained. So I would probably move on to next question. And Nafisa, please.
Next question is indication of MRI. What is the indication of MRI for the breast?
Relating to breast.
Yeah.
So we got our radiology faculties. Please answer.
Yeah. MRI.
Because ultrasonography is to some extent person behind the screen is related, and machine is a factor. But in case of MRI, it is very sensitive to soft tissues, and there are many sequences. There are many sequences in MRI which is sensitive in smaller changes of tissue change, like your hydrogen ion, and therefore MRI is very sensitive. If we have suspicion after the mammography or tomosynthesis, but I am in doubt whether there is malignancy or tumor or not, then you may refer it for MRI.
Humayra?
MRI, we usually do if we do not catch up with ultrasound or mammogram, but we still think there may be something within the breast. In that case, MRI is done, and MRI, as Dr. Shibendu has mentioned, picks up very smaller lesions, and that can help us in early detection of small malignancies like, less than 1 cm, as we have mentioned before. So MRI, when we do detect such lesions which are not seen by ultrasound or by mammogram, when MRI picks it up, we immediately put a hydromark there and don't want to lose it for future assessment, which will be gradually done through MRI, not by mammogram or sonogram, because it did not, we did not see it in the initial stages. Because with insertion of hydromark, we will give new adjuvant, and the lesion will become further smaller and make it more difficult to see even in MRI. But the marker will be seen, and then and there, the wire localization can be also done through MRI and send the patient for surgery.
Thank you. Can I just say a few words?
Okay, thank you.
With regards to breast imaging and role of MRI, the typical image is mammogram, ultrasound, and biopsy. That's it. But there are occasions where you could find a lump and you're not sure. Mammogram is normal, ultrasound is normal, and you don't know. So obviously you could do an MRI. Suppose you got a core biopsy, and if it comes out as invasive lobular cancer, the lobular cancers could be multifocal or they could be bilateral. And therefore, we do routinely request MRI post-core biopsy proven invasive lobular cancer to exclude multifocality and to exclude contralaterality. Plus, a young patient, very dense breast, comes with a breast cancer, surprise. Mammogram could be benign, M2. Ultrasound could be U3 or U4, suspicious or indeterminate. and you've done a core biopsy, it turns out to be a breast cancer. In that case, for young patients to evaluate, you'd want to get an MRI. Any patient who gets a neoadjuvant chemotherapy, we routinely request an MRI, pre-neoadjuvant chemo, and post-response after completion of neoadjuvant chemo. We also do an MRI to see the downstaging, how much it has taken place. Plus, if there is a clinical discrepancy versus images, suppose you examined a lump which feels 6 centimeter, but mammogram says it's 2 centimeter lesion, and ultrasound says 2.5 centimeter. So there is a discrepancy between clinical versus image. And that's when there is also a role for MRI as well. So it has got a wide range of uses, but we do not like to use it upfront as a screening tool because we know that mammogram is a proven image screening tool. It's well recognized. But when you talk about sensitivity, as Professor Shibandu quite rightly said, it's almost 98 to 100% sensitivity, and specificity it gives about 88%. Comparing to mammogram, sensitivity is about 88 something or less than 90%, and I think ultrasound is 72%. But screening tool-wise, mammogram still has a well-proven, established role across the world. Over to you, Nafisa. Thank you.
Thank you, Dr. Farid Ahmed. Another question is, stereotactic biopsy always taken by mammography? That means, is the term stereotactic synonyms with mammographic biopsy? Please answer, Humaira Madam.
In stereotactic biopsy, yes, mammography is done prior to the biopsy. And in X-ray room where the biopsy is taken, the patient is either in lying down position or in a sitting position. And the needle is placed according to the measurements from the skin and nipple areola. And a small incision because the stereotactic biopsy needles are very thick. And it is guided through mammography where the needle is going. And then it is automatically, the needle is revolving. 12 cuts are usually taken, but sometimes lesser cuts with adequate samples may also be taken, and they are immediately X-ray screened to see whether there is calcification or any other changes of the breast tissue to go ahead with other treatments.
Brilliant. The one thing I'd like to just to add, Nafisa, Humaira excellently described it. It's simple, just to make it simple. If there is a lesion that is not seen on ultrasound, so typically sonologists do an ultrasound-guided core biopsy. So if you cannot do that, and obviously it is seen on mammogram, then it is, as Humaira rightly said, that is called a stereotactic core biopsy that is done through mammogram. Thank you.
Thank you. Another question: which radiological modality is good for tumor size comparison after neoadjuvant to look for response? Dr. Kamrujaman sir, please, sir, answer this.
Can you repeat the question? Which
radiological modality is good for tumor size comparison after neoadjuvant to look for response? Asked by Aksa Khan.
Actually, if you think is that if you use, before going for any chemotherapy, if you use the ultrasound measure, you will have to measure with the ultrasound. If you use the MRI measurement, then you will have to use the MRI. Same modality should be taken before chemotherapy and after chemotherapy. Same, yeah. If you do the MRI first and take measurement in ultrasound, that will be not accurate. You will have to use the same machine, same technology.
Dr. Farid sir, can you say something what you are in UK?
Professor Kamrujaman Bhai has brilliantly said it has to be same way, otherwise you will be getting confusing answer. Ideally MRI, but in Bangladesh you don't find MRI facilities available in remote areas. In that case, at least do an ultrasound, which, as Kamrujaman Bhai said brilliantly, it has to be same modality so that you see the response. I think the answer is beautifully given.
Another question by Saidul Anwar. I want to know how small lesion can be detected by mammo, ultrasono, and MRI respectively. Please, Dr. Shibendu sir. Please, Dr. Shibendu sir.
Beginning from your MRI, MRI is very sensitive your not millimeter, a tissue change is sensitive. Your mammography, few millimeter, 5 millimeter or less is also, if it is digital mammography or tomosynthesis, then it is measured. And in ultrasonography is also very sensitive in high frequency probe. A few millimeter change or architectural distortion, if we see it with patience, then it will be detected. Even the papillary carcinoma, only architectural distortion or microcalcification, then ultrasonogram and your mammogram, high quality mammogram is sensitive.
Thank you, sir.
There is no exact measurement. 5 millimeter is the cutting end, 3 millimeter is the cutting end. There is no cutting. It depends actually upon the machine and the man behind the screen.
Another question from Dr. Asifa Tasneem. After a patient has completed radiotherapy, should we wait before going for imaging investigation? Please, Professor Kamrujaman sir, can you say? Please?
Definitely. Is along with, because if you do the BCT case, if you treat the patient with a radiation therapy, there will be fibrosis. It will take some time, and there will be fibrosis that will gradually occur. So it will take near about 6 weeks to resolve the fibrosis. So after that, you will have to evaluate whether there is any lesion coming up or not, any recurrent lesion is coming up or not. So you'll have to give time to resolve this fibrosis in the breast, especially.
Dr. Shibendu sir, can you add something about this?
No, it is very important. If you goes with post radiotherapy stress, it will be confused. As Kamrujaman sir said, a certain time limit should be given for the exact improvement or regression of the.
So how long?
Can I ask a question to Kamrujaman bhai?
Yeah.
Okay, I think absolutely all right. But,
what you do actually in colorectal cancer, we do neoadjuvant CCRT, and we wait for 6 to 8 weeks to resolve and then to go for the surgery.
Yes, of course. But the thing is that in breast carcinoma after radiation, do you wait 6 to 8 weeks only to resolve the radiation, edema, and fibrosis, all these things, or you like to get the maximum effect of radiation? What is given 6 weeks back?
In breast cancer, actually, radiation is given at the later after chemotherapy. So after completion of the chemotherapy, we go for radiation therapy. And radiation therapy is the end of the treatment. So after giving radiation therapy, we wait for 6 weeks to see the diseases come back in the place of the tumor or not. So we can wait 6 to 8 weeks to have the ultrasound or MRI things we need to do actually. After 6 weeks, we evaluate the breast lesion is whether residual is there or no residual. Actually, recurrence is occurring in the breast sites or not. That's the main thing, especially in the breast, not before 6 weeks.
I would like to add some. Thank you, sir. I would like to Dr. Mohiuddin sir to add something about this. How long you wait for the imaging?
Normally, follow-up mammogram we wait at least 9 months, and so 9 months is the cutoff year. So after 9 months, we do the follow-up mammogram, and those patients receive, radiation therapy and already diagnosed with breast cancer, they do yearly mammogram then after that.
No, regarding Mohiuddin is regarding sonography actually, not mammography, because in BCT case, recurrence is more in the breast tumors.
Hello?
So we'll have to see the ultrasound whether the breast is coming out, not the mammography. The BCT case treated with radiation therapy, that they are asking.
Oh, we normally don't do ultrasound after finishing the radiation. We wait, at least 6 to 9 months.
6 weeks, definitely. But it's a long, I think it's a protocol of the your centers, especially.
No, I could not understand about the Mohiuddin's reply. Is it 6 to 9 months or 6 to, what is the question actually, Nafisa?
question, I think they said after finishing radiation therapy, when you do the follow-up mammogram, I believe. So
Is that what
after
it was the
Imaging,
neoadjuvant? No, no, no.
imaging.
I thought the question was it was the neoadjuvant radiation. How long you have to wait before going for surgery?
No,
No, that has already been answered.
That is
That's been answered.
Okay.
Some average is 4 weeks practice, but the question that was asked was, patient had cancer surgery and has treatment, adjuvant treatment of radiotherapy completed.
And follow up. Okay.
And now, when would you want to do a mammogram? As Mohidin Bhai rightly said, we would wait at least 6 months to 9 months. And normally it's an annual mammographic surveillance. But what Professor Kamrujon Bhai was saying was,
sonography.
if there is a lesion that needs an imaging, then ultrasound scan can be done anytime, but preferably after at least 3 to 6 weeks.
6 weeks.
Yeah, ultrasound is, it depends on when you see the patient coming with, still persistent swelling or something like that, then you can do it after 6 weeks, definitely. But mammogram we do after 9 months.
Yeah,
I agree.
Definitely. Because in mammogram, you will see the calcium calcifications, because if the lesion doesn't have a calcification, if the lesion goes with a solid tumors, so you will have to see the changes in the ultrasound or MRI. This is coming back or not, because in breast cancer, first 2 years are very important for recurrence, and in BCT case, usually recurrence occurs in the site of tumors.
I would like to, Kamruzaman Bhai. Ultrasound after radiotherapy is very difficult to see the breast. So this is very important because the skin becomes thick and edematous, the underlying becomes, and also we see in many cases that it fails to detect the site of the lesion. And because the sound wave cannot penetrate through these thick tissues into the area of lesion. So at times ultrasonogram here is not very useful after radiotherapy.
Yeah, in that case, you'll have to add MRI and other things.
Years of radiotherapy, the skin thickness and the subcutaneous thickness change, it persists and makes it sonography very difficult. So in this case, MRI is
more helpful. That's why we frequently follow the patient, because in BCT cases, always ultrasound is really suspicious always.
Yeah.
In that case, can I give you a scenario? Suppose patient has completed radiotherapy, post breast cancer adjuvant radiotherapy completed, and after 3 months, patient comes with a very tender throbbing swelling. So ultrasound needs to be done. You really don't want to do MRI, and probably it's an abscess, and all you need is an ultrasound guided aspiration with an abscess, or it could be a cancer recurrence. Say you completed chemotherapy, radiotherapy, and patient comes out with recurrence after 4 months. It's possible, rare, but it's possible. In that case, images do have a role, starting with an ultrasound and perhaps an MRI or an ultrasound guided biopsy, and staging, obviously. Thank you.
I have one question. As lots of sonologists and radiologists here, after complete of radiotherapy, 3 months later, patient came with the ultrasound report with a 3 small solid lump. As the operation already done, radiotherapy already done, after 3 months, when the lesion is ill-defined, ultrasonologists call that is there is ill-defined 1 centimeter lump, is it signified or not? Patient thought that he or she have got another lump, another cancer.
In this case, as Farid has already said, you need to do another core biopsy to see whether there is recurrence or not.
After 3 months, only after 3 months of the radiotherapy?
Because the sonologist is saying that she is seeing, or he or she is seeing 3 small tumors there. 3.
So we have to do another.
Yes, you need to do a repeat core biopsy.
But Dr. Humaira, can the MRI can differentiate between the old scar and the early malignancy?
MRI can differentiate?
Yes, can. Whether it can.
It can.
Scar and the very early malignancy.
Yes. MRI can. MRI can. Especially MRS. And your DW image. can differentiate between scar and the malignancy.
In UK, our sonologist quite cleverly describes on their sonology report, old surgical scars, clips are seen there, surgical scar, or if it looks suspicious, they will differentiate that. It can also be seen on mammogram, but obviously MRI is more sensitive.
Another question from Aksa Khan, early marriage and then multiple pregnancy is protective for breast cancer. Can you please explain again why screening early compared to West? Actually, she wants to ask that why our screening program should start early. As we married early, pregnancy with multiple pregnancy, why early? Dr. Humaira Madam, Shivendu Sir, Kamrujaman Sir, please say something about.
না এটা ডক্টর হুমায়রা বলেছেন যে আমাদের দেশে যেহেতু প্রেগন্যান্সি আগে হয়, ব্রেস্টটা রিডান্ডেন্ট হয় বা ফ্যাটি টিস্যু চেঞ্জ হয়, সেই জন্য আমরা ম্যামোগ্রাফিক স্ক্রিনিং আগে থেকে শুরু করতে পারি, কিন্তু উনি এটার উত্তর দিবেন আসলে।
Papa, unmute yourself.
এটা আমাদের দেশে আর্লি স্ক্রিনিং করা হয় বিকজ আমাদের দেশে প্রেগনেন্সি, ল্যাকটেশন এবং আর্লি ম্যারেজের কারণে যেটা বলা হয় যে স্ক্রিনিংটা আমরা আগে শুরু করি। ইয়েস, ইন অর্ডার ওয়েস্টার্ন ওয়ার্ল্ডে যে লেট ম্যারেজ, লেট প্রেগনেন্সি এবং সিঙ্গেল থাকার কারণে ওদের ব্রেস্টের যে চেঞ্জেস গুলো এগুলো পরে আসে, এবং আমাদের দেশে আমরা এই চেঞ্জেস গুলো আগে পাই। So in that case, we can screen the patient approximately every 2 years to find out that if there is any. Yes, sorry.
No, carry on. You carry on. আপনার পর আমি একটু বলবো।
To find out any kind of lumps or solid anything going on.
I'll just quickly say that there are 26 countries in the world are running national screening program, and UK is doing 3 yearly screening from 47 age starting 3 yearly basis until 74, and other countries are majority doing 2 yearly, and one country is doing, I think, annual basis. Now, the point that was asked in that question was relating to the age, screening age. In Bangladesh, we are seeing a lot of young patients coming with breast cancer, and their ages is around 35 and around. And this is a worrying sign. And there is, I've seen one paper published in Dhaka as well with the screening age things. The problem for us is we haven't got a national cancer registry. We haven't got a national screening program. We haven't got a national cancer database. Therefore, we cannot say for sure which age is accurately right for us. In UK is 30 years. They've been running this screening program, and the age has been modified. And age 47 is started only about 5-6 years back. Previously, it was 50. So we cannot compare apple to pear. And in Bangladesh, because of the patients getting married, having children early, these are protective. They are obviously protective for breast cancer. But what we are seeing an increasing number of triple negative cancers in Bangladesh. In our practice, the data we have got our individual units, we are seeing increasing number of patients who have got genetic mutation. And we are also seeing younger patients getting breast cancer. Adding in all these factors, it is perhaps recommended we could start screening a bit earlier than Western country. And we, based on our limited data we have got, that is the recommendation we are making, as we lack any national definitive data and structure model.
I want to add, can I add something? I have a publication and I have a research work where very limited people with breast cancer is there. The standard mean age was 36 minus 2 standard deviation. And another study was done in Dhaka Medical. Also, limited people is there, and these are the same. And my colleague who seen lots of carcinoma, they all agree with me that 35 to 40 years is the peak age for breast cancer, and lots of people are coming with breast cancer at this age. So if we started breast screening at 40 years, we missed lots of early breast cancer. That's why we tell that 35 is the standard, but not it is a national database, but we have in our center last year we have seen more than 200 breast cancer patient, and I wait for another 1 year to publish a huge data, 500 or 1000 data with age variation, and then we can say something more confidently. I have can I ask next question from Saidul Anwar? Question question: what is the significance of doing core biopsy again in a recurrent breast cancer? Is there any possibility of changing risk status or histological diagnosis? Why? Can I ask this question to Dr. Mohiuddin, sir? Dr. Mohiuddin, sir, can you say something? Or
So,
Mohiuddin, sir, please.
core biopsy for recurrent breast cancer.
What is the
What was the
significance
question?
of core biopsy again
For
in
recurrence.
recurrent breast cancer? Is there any possibility of changing receptor status or histological diagnosis?
I think the possibility is rare. Is if there is a recurrence, it will be the same cancer.
Please, sir.
Thank you. Very good point, Mohiuddin Bhai. But what Saidul is asking, if cancer is recurring, suppose you've done surgery, had adjuvant treatment complete, patient comes with another lump. How are you going to find out it is a recurrent cancer? You have to have a tissue diagnosis. And therefore, an ultrasound guided core biopsy is a must. And once you've done that, you also need to have ERP or HER2, because although rarely, but it can, tumor biology can change. And
it's very rare, yeah.
ER positive could be negative, HER2 positive could be negative, or negative could be positive, but it's very rare. But the point is, what Saidul is asking, whether we do need to do a core biopsy. To definitely diagnose a cancer recurrence, you cannot rely on hand examination or ultrasound or mammogram. You have to have eventually a tissue diagnosis. Thank you.
Thank you. My another question, Jasmine Arifin Mili. You are there. Can you ask question by unmute yourself? Or I have to ask? Jasmine.
Carry on, please.
Mili, this madam, thank you for your nice and informative presentation. In case of axillary lymph node biopsy, by core needle biopsy, what size are safe? Core needle, for core needle biopsy, what size of core needle is safe?
Already answered.
Already answered.
14. Already answered by Humaira.
Another question for Jennifer Ishita. Assalamu alaikum. After breast surgery, how long we should wait to start adjuvant therapy? If there is any delay due to wound infection or disease, how long it can be delayed safely? Please answer this question.
Yeah, usually chemotherapy started 4 to 6 weeks after surgery, especially within 4 weeks or 6 weeks after surgery. But if there is infection, other things, infection has to control, then you have the chemotherapy. You cannot delay chemotherapy. If you delay for the 3 months, it will not be effective, because the data, the trial data are not done with 3 months after surgery. Chemotherapy has been given, and the trial shows the benefits. So you have to use the chemotherapy as early as possible. Usually 4 weeks, within 4 weeks after surgery, if there is everything is okay.
Thank you, sir. Sir, I want to introduce one person from Prominent Healthcare, Mahbub Bhai. Are you there? Actually, maybe not. The Prominent Healthcare, Mahbub Moshed. Actually, he gave us the support of wire and hydromark and core biopsy needle and medium reconstruction. Actually, I want to thank him and for his, hello. Is there. Can we close this program? End of this program, sir. Any question or?
Thank you very much.
Last one point.
Yes, sir.
One question from my side.
Yes, sir.
Dr. Farid, to pick up the very small distance metastasis, what is the present protocol in UK? Suppose there is some, you are suspecting some bony metastasis. Are you going with a radioisotope bone scan, or you are going with a PET scan? Or when you are going to advise PET scan to your patients?
Thank you. Very good question. Ideally, it is commonly practiced if you suspect there is a distant metastasis or a cancer recurrence, we like to do a CT chest, abdomen, pelvis. But if it is specifically with a bony symptoms, you suspect there is a bone mets, we do a whole body bone scan. And if the bone scan shows some lesions which is not sure, and we done a CT scan, staging, chest, abdomen, pelvis are all clear, but that bony lesion you are not sure, then perhaps an MRI we go. And if the MRI is not sure, that is the final one is PET scan. That is like a stepwise. But obviously, if in a country like in Bangladesh, I know in Dhaka have got already several PET scan available. And if you, it would be probably cost effective avoiding with the bone scan followed by MRI and then jumping into PET scan, rather than you do a PET scan. You can do it, but it depends on your availability. But the standard is CT chest, abdomen, pelvis, and a bone scan.
Yeah.
Would you agree, Mohideen bhai?
Yeah. Can I add one thing? Yeah. Thing is that you'll have to know the biology of the tumor, especially if the tumor is plastic, then bone scan will be more effective because the technician will sit in the tumors. Yeah. If it's a lytic lesion, in that case, usually FDG goes to the tumors. It is because the tumor is very fast growing and it involves the FDGs. So FDG will be more prominent in the PET scan, especially when the tumor, if the tumor is just rapidly proliferating and FDG sensitive. And what Farid is telling, yeah, step by step we'll have to go. Yeah, you can do the MRI. It will show the anatomical distortion of the tissue. But thing is that step by step. For example, Bangladesh, you can go for the, especially if there is symptoms, you can go for the X-rays. Then you can go for the bone scan. Is cheaper. Then you can go for the MRI. Then you can go for the PET scan.
Sir. Yeah, I agree with Dr. Farid that, as you know, that a breast tumor is the osteotropic tumor. So in my practice, most of the time, if any bony pain, we do the whole body bone scan and CT chest, abdomen, and pelvis. Rarely we do PET scan.
Definitely.
That's correct.
Sir? Please. Nahar ma'am.
জি জি আমি স্যার আমি আসলে মাঝখানে ডিসকানেক্ট হয়ে গিয়েছিলাম আমি একটা কোশ্চেন করেছিলাম তো আমি আনসারটা ওই ডিসকানেক্ট টাইমে আমি বলতে পারবো না আমি আবার ঢুকতে পেরেছি আর কি এখন এটা কি আসলে আনসার দাও
Can you ask your question again?
In case of TNBC patient, what is the role of radiotherapy after mastectomy?
TNBC actually ইন্ডিকেশন হচ্ছে টিএনবিসি হলে হবে না বিকজ আমরা রেডিওথেরাপিতে যে টিউমার যদি মোর দেন 4 সেন্টিমিটার হয় মোর দেন লিম্ফ নোড যদি একটা পজিটিভ থাকে তাহলে আমরা রেডিয়েশনে যাই রেডিয়েশন কত ইন্ডিকেশন আছে টিএনবিসিতে রেডিয়েশন দিতে হবে তা না এরকম কোনো ট্রায়ালও নাই যে টিএনবিসিতে আর্লি কেসে রেডিয়েশন দেওয়া হচ্ছে রেডিয়েশন ইন্ডিকেশন আছে যদি মোর দেন 4 সেন্টিমিটার টিউমার্স আর আরো কিছু ক্রাইটেরিয়া যে আছে যেরকম লিম্ফ নোড যদি একটা পজিটিভ থাকে তাহলে আমরা রেডিয়েশন post mastectomy or post operative radiation job otherwise not TNBC usually chemosensitive tumors mostly chemotherapy দিয়ে treatment করা হয়
thank you sir
thank you so can I close and
this you should
হ্যাঁ আমরা নামাজ পড়তে যাব এদের ক্লোজ করা উচিত
thank you all
নামাজ পড়ি নাই
আসরের নামাজও পড়ি
আসরের নামাজ পড় হ্যাঁ আর মিস হয়ে যাবে
sir thank you all Mohideen sir Anwar sir Sadat sir Shibendu sir Kamrujan sir thank you Rafiqul Salihin sir thank you all, Humaira madam. Especially thanks for this nice presentation. We want to disseminate that whole thing.
It's a very, very vast thing.
So
thank you.
We hope we'll have a next session very soon.
Thank you, Dr. Humaira. It was an excellent presentation.
Yeah.
Thank you all. Thank you, the organizer. Thank you, Dr. Farid and Dr. Ali Nafisa. And thank you, Kamrujan Bhai, and all other faculty. And one last comment, because all legendary, surgeon, radiologist, and oncologist is there today's meeting. I really appreciate, I believe that our surgeon, our doctor are very good doctor, but they need little bit of twinning. I mean, they
Definitely.
need some, short course training. So
Training and
now
technology
we
also.
have this is the golden time for the Bangladesh doctors of Bangladesh, because our DG is a surgeon. He's a renowned surgeon and very educated guy. So we should use him
Yeah,
at
he's my
least,
classmate.
we
He's
should
my
use
classmate
him,
from my community
because
college. Yeah.
I suggest that from whole country, we need to recruit at least 2 surgeon, 2 radiologists, 2 pathologists from each medical school, and send them for short course overseas training, at least for 3 months. So because medical education, ADG medical education, also a surgeon, I believe, ophthalmologist maybe, and money is there.
Yeah,
So
Inayat,
some
yeah.
money is there, So somehow I think our leading surgeon, leading radiologist, oncologist, they should try to train our next generation, surgeon, radiologist, oncologist, everybody. Otherwise, what we earn today, we have to we will give all this money to Mount Elizabeth. Thank
Yeah,
you.
I think Mohiuddin will also contribute in this
very
matter, especially just Farid is contributing in the country. I think you should come up with this type of contribution regarding training and other things. And you are.
No, training, you see, training is possible, but there is a money involvement. You see, if someone from Bangladesh come and leave their practice for 1 month, so his family need to support his, someone take care of his, airfare, accommodation, everything,
Young generation
So,
should come for the
yeah,
training, especially.
otherwise,
not the practicing one.
our
Not the
surgeon,
practicing
our
one.
doctor are very good doctor in Bangladesh. I can, that's why
But
we are
you will
here,
be very happy to see that. Very happy. You'll be very happy to see that Bangladesh medical profession has developed tremendously. They're trying to run in parallel with the world, and just only needs cooperation, coordination, and help from every corner.
Inshallah.
Yeah.
Thank you all.
আমি একটুখানি বলি, সেটা হচ্ছে যে বাংলাদেশের 60% to 70% হেলথ সার্ভিস দেয় কিন্তু নন গভর্নমেন্ট। গভর্নমেন্ট হচ্ছে 30 to 40%। সুতরাং শুধু গভর্নমেন্টের উপরে জোর দিলে হবে না যে ট্রেনিং নিডেড।
না আমরা তো পার্সোনাল দিলাম।
না, এখানে মানি ইনভলভ তো, প্রাইভেট তো করছে, গভর্নমেন্ট তো করছে না।
না প্রাইভেট করে না, প্রাইভেট এ ফিউ করে, এবং যারা করতে যায় তারা ব্যক্তিগত
আমাদের
উদ্যোগে যায়।
দিয়েছে প্রাইভেটলি, আপনি চলে আসেন, আমাদের সবাইকে ট্রেন্ড আপ করেন, অসুবিধা নাই, উইল সেন্ড ইয়াং গাইস।
না অ্যাট লিস্ট মাঝে আসেন,
পাঠাবো।
এখন আমরা প্রাইভেটলি আসি অর্ধেক সকাল বিকাল।
ওকে, আমার মনে হয় যে সবাইকে খোদা হাফেজ।
It was a nice meeting. Thank you very much.
Thank you Dr. Farid.
Thank you.
আমাকে কানাডাতে একটা সার্জারি ট্রেনিং এর জন্য অলরেডি আমাকে রিক্রুট করছে, কাগজপত্র চলে এসেছিল, শুধু জন্য কমপ্লিট করতে পারি নাই। স্যার কিন্তু আমাদের হেল্প করছেন, আর স্যারের হেল্প তো বলে শেষ করা যাবে না, কারণ মডার্ন ম্যানেজমেন্টটা আমি স্যারের কাছেই শিখেছি একেবারেই। যেখানে ওয়ারও আমি ফার্স্ট টাইম স্যারের কাছে, বাংলাদেশে স্যারই ফার্স্ট করেছেন, হাইড্রোমার্কও স্যারই বাংলাদেশে ফার্স্ট টাইম, ইভেন এডিএম রিকনস্ট্রাকশনও ফার্স্ট টাইম, এবং এই যে প্যাটার্ন ভিডিও এসএমবি ফার্স্ট টাইম। সো আমি বলতে চাচ্ছি স্যার আমাদেরকে কন্ট্রিবিউট করেছেন, এবং মহিউদ্দিন স্যার কিন্তু অলরেডি কন্ট্রিবিউশন শুরু করেছিলেন, বাট আমি যেতে পারি নাই, এবং আরো হয়তো করবেন, এবং অনেকেই হয়তো ফ্যাসিলিটেট করবেন। তবে আমি যাব, করোনার জন্য পিছিয়ে গেছে, তো স্যার কিন্তু খুবই আন্তরিক। স্যার থ্যাংক ইউ স্যার, সবাইকে অসংখ্য ধন্যবাদ আমাদের এই প্রোগ্রামে সাপোর্ট করার জন্য। আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।
Thank you very much.
See you
Walaikum salam.
Thank you.
Inshallah.
Assalamu alaikum.